Today I'm joined by Professor Janice Rymer, a renowned expert in obstetrics and gynaecology, and a consultant gynaecologist and Professor of Gynaecology at King's College London. Professor Rymer is celebrated for her groundbreaking contributions to medical research, education and clinical care. Specialising in menopause, reproductive endocrinology and minimally invasive gynaecological surgery, her research has been instrumental in shaping modern approaches to managing menopause, including the use of hormone replacement therapy and the development of innovative treatments for complex gynaecological conditions. As a passionate educator, Professor Rymer has trained countless medical professionals, sharing her expertise through academic lectures, workshops and publications. As an academic author, she has also contributed to numerous peer-reviewed journals and textbooks, and is frequently invited to speak at international conferences, which is why we were able to catch up in Melbourne. Today we're taking a deep dive into endometriosis. What is endo? If you have painful periods, does this mean you have it? How is minimal access surgery used as a tool for diagnosis? And how can you manage living with endometriosis while maximising your quality of life? Let's get into it. So, Professor Janice Rymer, thank you so much for joining me today on the podcast. It's such an honour and privilege to have you here. I know you've travelled to Melbourne to attend the World Congress, and I really appreciate you giving me some of your time away whenever I know you're really busy. I would love you to tell our audience a little bit about you and why you've ended up with the special interest that you have.
Well, I was trained in obstetrics and gynaecology. I'm a clinical academic. And I used to do obstetrics until about 13 years ago, and then I had to give it up because I became dean of the medical school, so I couldn't do both. So then I just did gynaecology. I've always been interested in minimal access surgery and have ended up doing a lot of endometriosis work. And then when I was first at Guy's, I did a lot of clinical trials in menopause, particularly to do with bone loss, because that's what I did my thesis in, was HRT and bone loss. So yeah, I've just ended up with two areas of my interest, endometriosis and ovarian failure.
Okay, so today we're going to focus on endometriosis. I wonder if you could tell the audience what actually is endometriosis.
Endometriosis is where you have the lining of the womb outside of the womb, basically. And I find it absolutely fascinating disease because you can understand that could happen with retrograde menstruation, like the endometrium instead of going out through the cervix and the vagina, it goes through the fallopian tubes, out through the fallopian tubes, into the pelvis. That all makes a lot of sense. But then you get endometriosis in other parts of the body. You can get in the chest, you can get in the diaphragm. So that doesn't solve the whole problem. So there are other theories as to how it spreads as well. I find it a fascinating disease. The more you sort of do or see patients with endometriosis, you sort of think, I really don't know much at all. I think it's an incredibly complicated disease, but we're certainly seeing a lot more of it. And I think that's because of people delaying having children. You know, the exposure to menstruation, if you like, is a lot more now than, say, my parents, your parents kind of thing.
And in terms of, do you think it's becoming a more common condition because something's changing, or do you think it's becoming a more common condition because we're diagnosing it more?
Yeah, I think it's multifactorial. I think the awareness of endometriosis is becoming more. So people are thinking, oh, God, these terribly painful periods, maybe it's just not painful periods, which I'm told it is. Maybe there is actually something causing it to be so painful. Yeah, so I think it's multifactorial.
And let's talk a little bit about that. So I think lots of women kind of expect that their period will be a bit crampy. What is the range of normal, or how do we know when the pain is a bit more than what we would expect?
And that's the thing, it's really hard because, N equals 1, it's only you, isn't it? But I think if women are taking time off education or they're taking time off work, I think that's really significant. And if you talk to them about, symptoms, they may say, well, actually vomit with the pain. Well, that's not normal. And then, when you examine women, sometimes they've got hot water bottle burns on their tummy. Well, to me, that's actually pathognomonic of this is really serious. This is probably endometriosis, because if you're actually burning yourself with heat, then that pain must be pretty significant. So I think, taking time off is if you can't go to work, pain is so bad that you sort of have to lie on your bed for a day or two. That to me is very significant.
And so painful periods are one of the symptoms. What are the other symptoms of endometriosis that we might be having?
If you have endometriosis in the womb, in the wall of the womb, the muscle of the womb, which is called adenomyosis, that can also lead to having very heavy periods. Yeah, so that's one thing. And then other symptoms you can get, we are seeing quite a lot of endometriosis on the diaphragm these days. So sometimes people might get, right-sided pain, just under the chest really. So that's another symptom. And the other big one is pain with intercourse.
And what's causing that pain then?
Well, you've got the endometriotic deposits, and each time you're having a period, they are going to get stimulated. So you can get bleeding in the deposits of the endometrium, and then you can get an inflammatory reaction around that. And sometimes things can stick together. Tissues can stick together if there's they're bleeding, and inflammation, and say the bowel comes along, it might stick to the bowel.
And so I've had quite a few patients who complain of whenever they're going to have a bowel motion that it's very painful.
Yes.
Is that because they've got these deposits on the bowel?
Yep. One of the commonest sites of endometriosis is behind the uterus, between the womb and the rectum. That's a very common site of endometriosis. So women often say that passing a bowel motion is really painful, particularly at the time of their period.
Okay.
Yeah.
And would you expect the pain would settle then the rest of the month, or would they tend to be painful all the time?
Very good question. It can be painful all the time, but I think there's usually an exacerbation at the time of when they're having a period, or just before their period and the first few days of the period.
And is there a genetic element to endometriosis?
Certainly is. Yeah, there certainly is. I mean, many genetic loci have actually been identified, but certainly if a woman's got a family history of endometriosis, then she may well, she's got a high risk of having endometriosis, yeah.
So if someone's suspecting that this sounds a little bit like them and they think they might have endometriosis, what's the first step and how do you get diagnosed with this?
Well, they need to go and talk to their GP and tell them, that they've got really painful periods. Could they possibly have endometriosis? They may want to just try hormonal therapy, straight off, like taking the oral contraceptive pill continuously, or taking progesterone to stop ovulation, or having a Mirena. But the gold standard for diagnosing it is having a laparoscopy, which, is an operation, and no operation is without risk. So you need to take that seriously. And if someone's very overweight, then it's very risky to have a laparoscopy. So you've got to weigh all that up. But I think by the time they get to me, I think it's very important to do a laparoscopy because they need to have a diagnosis. But also when you do the laparoscopy, you can diagnose and excise what you can, excise the endometriosis that you see. So I think it is important for women to know what they've got. And also if you have got endometriosis, then you need to understand that it's a chronic recurrent disease. So you don't just have your surgery and that's the end of the story. You need to think, right, I've got the environment, whatever that might be, that promotes endometriosis, so I need to do something now to stop the endometriosis coming back. So at the laparoscopy, actually, that's when I really try and get people to have a Mirena, because you can do your nice surgery and then you can put a Mirena in, which will give that progesterone influence to stop further endometriosis coming. So I think that's really good to have a Mirena put in at the time of laparoscopy, unless you want to conceive, obviously, and then Mirena would be inappropriate at that time.
So if you do your laparoscopy, you see some endometriosis, you burn it off or whatever, and you put your Mirena in, how does the Mirena have any influence on what's happening on existing deposits that have already made it into that?
Yes, but hopefully you've got rid of those deposits when you do your surgery, unless, say, it was on the bowel and you may not want to go and excise it then, because you might call bowel injury. But because you've got that progesterone influence locally, you're absolutely right. It's going to dampen down any endometriosis if you left it.
Right, okay. And so once they've done that, perhaps they've got their Mirena or whatever they've decided to do, is there anything from a lifestyle perspective that we know influences this disease?
Well, I haven't seen good data on diet, but there are some people who will recommend diets, and I say to my patients, by all means, research it and see, and try it and see if it makes the pain better. But, I haven't seen any good randomized trials saying do this diet and do that diet and see whether that makes any difference. But also, I heavily believe in, normal BMI and exercise. I mean, I think that actually helps a lot of everything, really, doesn't it? So I would certainly encourage normal BMI, do a lot of exercise.
In my practice, I have come across quite a lot of, younger patients who have endometriosis, and they can get quite depressed.
Yes.
They can find that pelvic pain is quite debilitating. And I have a number of patients who have a lot of bladder symptoms.
Yes.
Can you talk to that a little bit for me?
Well, I think management of endometriosis in sort of an endometriosis centre has got to be multidisciplinary. And I think certainly the physios and the physios who help with pelvic floor physio, I think they can be really helpful. But also you've got to have your pain management as well. So I think it's really important to take women's pain seriously, help them with their pain, but also treating the disease as well. And I hope if you treat the disease properly, like exercise it and then Mirena or the oral contraceptive pill, hopefully you've come a long way to actually, relieving all these symptoms. But you're right, if you can't get on top of the pain, having pain all the time is just, the end of that is getting clinically depressed, isn't it?
In terms of pain relief, is there certain types of pain relief that seem to work better than others for this condition?
Well, most women do find response with something like ibuprofen and paracetamol, and alternating them, so you're taking something every 2 hours. But if that doesn't do the trick, then they might go to much stronger ones. But also, I think the pain centres are very good at perhaps putting in nerve blocks and things like that. So that's why I think it's very multidisciplinary. And women with severe endometriosis, need to have that multidisciplinary approach, I think.
So let's talk a little bit about endometriosis and fertility and why it causes an issue for women.
Well, there are two aspects to that. I think if you've got endometriosis that is actually causing anatomical distortion, let's say the end of the tube, it's attached to something else because of the endometriosis, then you can completely understand how that's going to affect your fertility, say tubal blockage, for example.
Yes.
But unfortunately, just the actual presence of endometriosis can adversely affect someone's fertility. Not all the time, but it can adversely affect it. And we don't really know why, but it might be that, let's say it's called factor X, means that retrograde menstruation will implant. That may also correlate with someone's, with their fertility. So, it's not straightforward, but that's why I certainly believe if you're doing a laparoscopy, you want to remove the endometriosis for pain, but also to improve someone's fertility.
And whenever we talk about using minimal access surgery, what does that mean?
It just means basically going through telescopes rather than opening abdomens up. When I first started training, that's what laparoscopy was only just coming in. And we started with laparoscopic sterilizations, but now so much more is done through telescopes. So it just means tiny little incisions rather than big incisions.
And what are the advantages of that for the patient?
Cosmetically, much better. Patients get up and out of hospital much quicker. Most of our laparoscopic surgery is day case, so they come in the morning, have their surgery and go home. Well, in the old days, you'd be having a big cut in your tummy and you'd be in hospital for 5 or 6 days. So it's so much nicer for women. They get over it much, much quicker.
I was reading there recently that endometriosis affects about 10% of women. Is that roughly right?
Yes, it's really hard to know the prevalence because some endometriosis doesn't cause any symptoms at all. So you're not going to pick that. You're not going to pick that up. But it's usually about 5 to 8% of the population. But you'd have to laparoscope the whole population to find out what the prevalence was.
And is there a correlation between how many deposits you have and how bad your symptoms are?
Oh, that's another thing about endometriosis. You may have just a tiny little deposit or a couple of little deposits and have very severe pain, or you may have severe endometriosis and very little pain. So there's a poor correlation between extent of disease and extent of pain.
Right, okay. And is there anything that people should do? Like, is early treatment better than waiting, or is there a case for a watch and wait scenario in this situation?
I think early diagnosis is important. If people are on the pill, say, and they're taking it continuously anyway, then obviously they're treating endometriosis if it's there. But otherwise, I do think it's quite important to get an early diagnosis, or particularly if they've got pain. You want to make the diagnosis and get on top of it.
I know that you have another big interest, which is that menopause and menopausal transition. I'd love to know, is there an intersection or overlap between endometriosis and the menopause transition? Like, do people with endometriosis have an earlier menopause or anything like that?
Well, if they, one of the end-stage treatments of endometriosis is to have a hysterectomy and to remove the ovaries. Now, clearly, that's going to mean that you're straight into the menopause when you have that done. But as far as I'm aware, I don't think there's any association between endometriosis and early menopause unless you've had surgery on your ovaries or you've had your ovaries removed.
And would that be an absolute sort of last resort treatment?
Yeah. Okay. I see it absolutely as a last resort. Yes.
Yeah, absolutely. And in terms of if someone has a history of endometriosis and they're presenting with lots of perimenopausal or postmenopausal symptoms, what do we need to think about more carefully?
Yes, well, that's right. There's this. It's challenging because if they're getting the perimenopausal symptoms, and you basically want to treat them, you might put them on cyclical hormone replacement therapy. Well, that might prolong the stimulation of the endometriosis, if you know what I mean. So it is quite a challenge. So I think you need to think, well, what are we going to do here? So something like the Mirena would be really good. Put the Mirena in, and then you can give the estrogen. So at least you're getting that progestogenic influence. So hopefully you're not stimulating any more endometriosis. And there are other things that you can do, like the GnRH analogues. You can give those with add-back. So there are other alternatives, but you've got to think to yourself, am I going to make this patient's endometriosis worse if I give her, cyclical HRT to sort of prolong the periods? Because one thing that endometriosis patients often look forward to is going into the menopause.
And so that's definitely a bit of a balancing act because they've maybe got to the end of their tether with their endometriosis.
Yes.
But the next thing, they get a nice serving of menopausal symptoms and they're in an all different type of hell, basically. Do we find that HRT versus something like the contraceptive pill, there's a different...
That's a really good point. And I think we probably don't use the oral contraceptive pill enough. I mean, what you could do with a perimenopausal woman is you put her on the oral contraceptive pill, say till the age of 51, and then you put her onto hormone replacement therapy, but maybe a bit later, because you don't want her to go onto cyclical. You want her to be on continuous combined therapy, so you're not stimulating it. But yes, I think the pill, and particularly now with the sort of the newer pills that are out, I think we could use that a bit more because that would definitely take care of your hot flushes and stuff if you go into the oral contraceptive pill.
So we've talked about medical therapy, we've talked about surgery. What other things do you think are beneficial to this group of women?
Are we talking about
endometriosis?
Endometriosis. Are we talking about perimenopause?
Yes, yeah.
Perimenopausal. What else is beneficial? Well, again, I guess it's the lifestyle things again, what we were talking about. Good diet, exercise, keeping yourself healthy, basically.
Mm-hmm. Is there any place with even whatever age of person with endometriosis for a pelvic floor physio? Are they helpful with this group of
pelvic floor? I think they're great. Like I was saying before, I think they're really, really good pelvic floor physios. We've certainly got onto them only in the last sort of 5 years or so, but they've been so beneficial with our patients. I think they're great.
Yeah, I was talking with we've got very good local pelvic floor physios, I have to say, and they were saying, they often see just this really tight pelvic floor where, it's probably related to chronic pain, but absolutely really, really tight. And actually, most women were talking about tightening up their pelvic floor, but this group of women, we nearly need to do the opposite. We're trying to relax it a little bit because they've clearly been holding everything really tightly.
Absolutely.
And in terms of if there's anyone listening who is concerned that they have endometriosis or maybe they have a family member, can you point us in the direction of any helpful resources or any groups that you think have really good info?
Well, I think, obviously I work in the UK, so I'm only familiar with those, but Endometriosis UK I think is a really good patient charity, and most women find the information there very helpful. And then there are forums and stuff you can go on to talk about things. But yeah, I think Endometriosis UK is great.
Yeah, look, we have listeners all over the world, so I think most countries will have a similar organisation. Is there anything that you would love people to know about endometriosis that you think generally people in the population just don't understand?
I think it would be quite nice if everybody knew about endometriosis, because one of the big problems is women with endometriosis in the workplace have a really tough time if they're having to take time off work, and particularly, I guess, with young male bosses, you're not getting much sympathy with that, and I think that's really important. So raising awareness amongst everybody about it, and how debilitating it can be. And, people talk about, this fractured life because you're having all this pain, you're not holding up your job, sometimes you have to change careers and all this sort of stuff. And then, as you were saying before, ending up leading to depression because this pain is absolutely debilitating and really messing your life up.
Yeah, absolutely. And in terms of what where are we going next? I know obviously you're very interested in research and you're obviously at a really amazing research centre. Where to next for endometriosis? Is there anything exciting in the pipeline or?
Yeah, I'm not really involved now in research at all, but the group in Edinburgh are certainly doing a lot of stuff. But hopefully there are things that will come along. But I don't know.
Yeah, at this stage we're just working with what we've got.
Yes, I think so. Yeah.
Thank you so much. You've been so helpful. I ask everyone who comes on the podcast a final question, which is, what piece of advice would you give to your 20-something self?
I think marinas are fantastic for women, and I sort of joke to people, say, newborns should be given a marina, because if you had a marina when you were born, then you wouldn't have any periods, but your ovaries would still kick in. You wouldn't have those horrible, painful periods that you do as a teenager. Then you could just have it taken out when you want to get pregnant, and then you get it put back in again. So you would never develop endometriosis because you're never going to have the exposure to menstruation. So that's what I would say. I would say 20-year-old, just have a marina and your life will be so much better. No heavy bleeding, no pain. Thanks very much.
Sounds pretty straightforward.
And then when you get to the menopause, you just have to add an estrogen to your marina. That's all you have to do. So it's a perfect life.
Yeah, that's right.
Course. Yeah.
I do personally insert marinas, but I will say if only they could make the insertion a little bit easier as well. And that would be just the cherry on top.
Yes.
Thank you so much.
Pleasure.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.